Good morning. So my presentation today is just an overview of Lyme and co-infections and discuss some of the issues that I've come upon over the last number of years. I've been practicing medicine for approximately infectious diseases for about 21 years and just took on the interest in Lyme disease in the last 5 years as patients were presenting to me very often with misdiagnosis. So ticks. What are ticks and what do they carry? This is a list of what ticks carry. They carry a Borrelia, the Lyme disease virus, bacteria, but they also carry lots of other bacteria, lots of other viruses, lots of other co-infections. So that's really important to know. The original strain that was discovered was Borrelia burgdorferi sensu stricto, but there's lots of other strains of Borrelia all over the world, including some strains that are not picked up by the current antibody test. Recently described Borrelia miyamotoi, relapsing fever borreliosis. We don't know if it's there until we start testing, and we haven't until recently started to test. This is a study that we did in Ireland last year. Somebody went out and picked the ticks from all over the country and ground them up and did PCR and tested them for Lyme. Same issue in Ireland. There are no ticks. They are not infected. Nobody has Lyme in Ireland. You have to do the studies. So we've done the first study, and the strains of Lyme that are being picked up in Ireland are Borrelia, not burgdorferi sensu stricto, but Guerinii, and other strains including miyamotoi, which is relapsing fever borreliosis, which is not picked up by any of the current strains. And also, when patients present, they very seldom have a rash. Miyamotoi almost never gives a rash. So we need to do the studies, we need to do the science. This is one of the first studies that's been done in Ireland looking at different strains of Borrelia, and Miyamotoi has not been recognized in Ireland until this study. On this slide is a study done by the vets, and they went out and they looked at the ticks around the animals in Ireland. And interestingly, the ticks in Ireland have Borrelia, they have Babesia, and they have Anaplasma, which is a rickettsial infections. The vets have done lots of studies. They have lots of diagnostics for these infections. They've got lots of understandings of the clinical manifestations of these infections in animals. We don't have the same understanding in humans. And I would propose that if those ticks are around animals and they're biting the animals and making them sick, probably they're making the humans sick as well. But we don't test for Anaplasma. We don't test for Babesia in humans. And we only have limited testing for the standard strains of Borrelia based on the American assays that are done. So there's lots of different tests available for Lyme disease. Are they perfect? No, they're not. We did a comparison of standard Lyme testing with some of the private testing that many of the Irish are doing. They get a tick bite, they're sick, their test is negative, so they're going off to Germany to do ELI spots and other testing done. And this particular ELI spot test that was done came out from a test in Germany, and we compared the standard Irish test to the ELI spot tests. And these were patients who were sick clinically with Lyme, who were told they didn't have Lyme because the Irish hospital tests were negative. And the ELI spot compared to the standard two-tier Western blot C6 ELISA assay was missing between 62% to 82 to 83%. So many of the private tests that are being done, which unfortunately many clinicians said are not validated, not accredited. They are validated, they are accredited. We're missing many cases. And people are going to get private tests because the tests are picking up the tests when the standard tests are missing them. This is the review of some of the sensitivity of the standard tests that's been around for years, 2005, 2007, 2011. The sensitivity of the current tests for Lyme are between 36 and 70% in one study, 20 to 97%, 34 to 50% in another study. The tests are imperfect. Every clinician, every patient should know that. You don't hang your hat on a test. They can be helpful. but you have to use your judgment and practice good clinical medicine. This is a summary done by Michael Cook that's published, looking at all the different tests: ELISA, C6, Western blot, two-tier. All the tests together are only 60% sensitive. So what does that mean for patients? If you've got a negative test and you're sick with Lyme, you've got Lyme. So what's the problem with the Lyme test? It doesn't pick up all the strains of Lyme. When you get a tick bite, it's not always Lyme. There could be a co-infection. I gave you a list of 30, 40 different bacteria that ticks carry. In Ireland, they're carrying Anaplasma, Babesia, as well as strains of Borrelia that are not being picked up by current tests. What does an antibody test mean? It means you have an immunological memory if it's positive. So a positive test means you've got it or you had it. It can stay positive for life after you've been treated. But you can have a negative test and still have the infection. And the currently approved testing all over the world misses many sick patients who are told they should live with it when actually they have a misdiagnosed, an untreated infection that is curable with appropriate antibiotics, okay? This is a study that's done in the UK recently, came out in British Medical Journal. They did an audit of over 8 million patients in GP practices. They then published it saying that there's not 2,000 cases in the UK, there's actually 8,000 cases in the UK. And this is all over the world. We're seeing increases numbers of patients with tick-borne infections. However, in response to this report, the government and special interests microbiologists put together a forum day for the press and basically said, this is not true. Most of the patients who are claiming to have Lyme have chronic fatigue syndrome. Chronic fatigue syndrome, by definition, is chronic fatigue in the absence of any other alternative diagnosis. These patients had clinical Lyme or had an antibody positive for Lyme. So we continue to, despite data coming out to saying that tick-borne infections are in the increase, we have governments and disbelievers within the medical communities saying that all patients are jumping on the Lyme bandwagon, pretending they've got Lyme. Maybe we're missing Lyme, and some of the patients who are jumping on the bandwagon actually have an undiagnosed infectious diseases that needs appropriate treatment. So, evidence-based guidelines for the management of Lyme disease, you have to use your clinical judgment. It's a clinical diagnosis, and other testing can support. Early use of antibiotics can prevent dissemination of disease, and that's the best time to catch it. If you wait till those bacteria have got into your bloodstream and disseminated to every tissue of your body, the cat's out of the bag. It's more difficult to treat. True for Lyme, true for Q fever, true for all infectious diseases. Why should Borrelia be different? The duration of therapy, 14 weeks, Bob, your uncle, you're cured. That doesn't work for cellulitis, it doesn't work for otitis, it doesn't work for most other infections, but that is the mantra given for Lyme disease. We have many patients, I have many patients who were treated, get better on doxycycline, then get worse again. They're told this is post-treatment Lyme disease syndrome, PTLDS. I would say it's partially treated Lyme disease. P stands for partially treated. We do this for any other infection. You wouldn't stop treatment for an otitis. If they get better, then they get worse. We shouldn't be doing the same thing for Lyme disease. So guidelines are guidelines. We should be treating patients, not treating guidelines. Do we always recognize a tick? No, we don't. A tick the size of a sesame seed. I had a patient recently that came into the emergency room, a month of pain all over the place and fevers, and he had a big rash on his back. That's why he came to the emergency room. He was told, oh, you didn't see a tick. And he was sent out to the emergency room. Oh, by the way, that rash, it was too big to be a bullseye rash. So this was the experts in my hospital sending a patient home, sent him to a dermatologist, sent him to a rheumatologist. Fortunately, I know these rheumatologists and dermatologists. They said, duh, this is Lyme, sent him back to the emergency room. I get a call from the emergency room. What did I suggest? Doxycycline for a month. He came back to see me a month later. Totally resolved rash, totally resolved rheumatology. And by the way, his antibody test that was done in the emergency room was positive. But this was almost a misdiagnosis. And this is patients presenting to an acute emergency room with the top infectious diseases in all of Ireland. So we're missing it, or almost missing it. What about all these patients that are showing up to GP practices? And I have story after story after story of GPs missing it, specialists missing it. And these are the easy ones. These are the ones that have the rash. But not everybody recalls a rash, and not everybody recalls a tick bite. So the EM rash, it's not as high as is reported in the medical literature. And there's lots of publications out there that show that. A few of them are presented here. Why are those articles not in the guidelines? The guidelines in Ireland say, oh, most people have a rash, most people have a positive antibody test, but that's not necessarily the situation. That's just the mantra from previous studies. But what about Ireland? We're not living in old Lyme, Connecticut, so maybe the rash is much less frequently there. So how do people present? Acutely, 3 days to 3 weeks after exposure. Symptoms, flu-like symptoms. If it's in the middle of winter, it's probably flu, but if it's in the middle of summer, maybe not. My patients often get told it's a virus. I would say, what virus? Great excuse. I've written in textbooks of antivirals. You have to tell me what virus. I think it's much more likely to be Lyme in Ireland, and probably more likely in many parts of the world to be Lyme or other tick-borne infections, and we should entertain it, and we don't. So the challenge is that once you get the rash or you get the inoculation of the bacteria, once you've got this flu-like illness, it spreads to every tissue of the body, and everyone's different. So you may end up with a dermatologist, a cardiologist, a rheumatologist, or a neurologist, and or a psychiatrist, and it's a challenge. So it is difficult to diagnose if you don't see the rash. Even when you see the rash, I've told you, people get sent out with creams or told it can't be Lyme because you didn't see a tick or the rash is too big. We need to improve our ability to think about Lyme and to diagnose Lyme. And we also have to think about what's the optimal treatment once the cat's out of the bag. Is it easy to treat with 3 weeks of doxycycline after it's disseminated everywhere? This is a classic finding. Bell's palsy, viral, maybe not. Maybe if the patient's perfectly healthy and you've got an isolated Bell's palsy, I've seen the studies. It's usually Epstein-Barr virus or VZV, zoster virus or herpes virus. But if you're hurting all over and have sweats and you have a Bell's palsy, it ain't a virus, it's Lyme. Number one in my diagnostic differential. Pains all over, migratory arthritis, and this is classic. You know, I have more patients treated with atypical rheumatoid arthritis that isn't responding to therapy. Lyme classically is migratory arthritis, and it can be months to months and actually years down the way from a misdiagnosis that patients are getting these symptoms. And this is well described in the medical literature, but it's not out there in the medical literature for some reason. So how commonly is Lyme and co-infections missed? 10 to 20% of patients identify a rash, remember a tick bite. 50% or less think it's a rash, and even if they do take the rash to the GP or elsewhere, it's often diagnosed as ringworm. They're told they have the flu, it's a virus. Then they show up later with lower white cells, lymphocytes, neutrophils, which is caused by these bacteria, Lyme, other co-infections. Anaplasma causes neutropenia. They're told they've got a virus and told to rest, give it time. I think the best treatment for a bacterial infection is antibiotics, not rest. So how do you diagnose? History. Multi-system involvement, a rash may not be there. Take a history. I had 3 patients this last week, and I said, with this mystery illnesses, and I said, well, have you been traveling in the last 3 months? Or where do you live? Ask them those kind of questions. Have you been fluish in the last month or 2? And then very often they volunteer they have a rash, or they volunteer an exposure that would make you be suspicious. So it's a clinical diagnosis. Take a good history and have a low threshold for suspicion. Early treatment will prevent later complications, and retreatment and longer treatment may be necessary. The guidelines say no, you're cured after 3 weeks. I have more patients better on doxycycline after 3 weeks, then they get worse again. Or you treat them for 3 weeks and then they're sort of better, and then you change them to different antibiotics and they continue to get better. Is this post-infectious? Is there this ongoing infection? We use clinical judgment all the time, but not for Lyme. So what happens if you don't treat Lyme? It disseminates the heart, the brain, arthritis. Okay, this is well described. Look at the study there from 1987. This has been around for 30, 40, 50 years. There's medical literature describing these infections that we're not looking at and paying attention to. We just look at the guidelines and say, Lyme is easy to diagnose and easy to treat. Do your homework. Look at the literature. Look at the studies that show that short-term antibiotics fail in 25 to 71% of patients with later stage disease. Okay, if you're 12 months down the way and you've got pains all over with a disease that looks like Lyme, 3 weeks of doxycycline ain't going to do it. If you catch Q fever, which is Coxiella burnetii, within 6 weeks with a pneumonia, 4 weeks of doxycycline, Bob your uncle, you're fine. But if you wait for a year and you're positive a year down the way without treatment, it takes 18 months of combination antibiotics to get people better. Known for other infectious disease, but no, not for Lyme. It's easy to treat. 3 weeks of doxycycline, a year down the way, and you're cured. But if you're not cured, it's post-infectious. This is bad medicine and bad science. We need better understanding of these diseases and better treatment regimes and better studies of what the optimal treatment are. So if your Lyme test is negative, you're told you don't have Lyme. Nobody seems to be aware of the co-infections. 25% of the patients I saw with chronic fatigue in my clinic that I did an audit, they were positive antibody for anaplasma, another tick-borne infection. Based on the history, I put them on antibiotics, and about 70% of them got cured of their chronic fatigue. So some cases of chronic fatigue are Lyme, other co-infections, and I'd rather have antibiotics for a few months than be given a diagnosis of chronic fatigue for life. So they end up going to cardiologists, rheumatologists, and neurologists. Is there such a thing as chronic Lyme? There's lots of studies out there show that it does disseminate, but there's still a debate. There is no such thing as chronic Lyme. It doesn't persist for more than a month or two, and after that, it's an immunological condition. Well, how do you know it's immunological if you're dependent upon antibody? You have to use your clinical judgment. There are some research studies that show that Lyme persists for months and months and years. There's case reports all over the world that report that it persists, but these case reports are largely ignored. I'm a member of IDSA. IDSA says there's no convincing biological evidence for the existence of symptomatic chronic B. burgdorferi infection among patients after repeat of recommended treatment regimes for Lyme disease. 2 weeks of doxycycline, Bob your uncle, you're cured. But this is a list of articles, and there's hundreds of them. Here, evidence of persistence of B. borrelia in human models. There's a recent case report in Antibiotics by Eva Sappi, showing a patient that died of Lyme with Lyme 10 years into treatment and 4 different organs on the post-mortem. Even before that, she was treated with standard treatment, and they took a biopsy of her skin, and they were able to isolate burgdorferi. They treated her. She got better. Every time they stopped the treatment, she got worse. They treated her again. She got better, and she got worse. Does Lyme persist? I think it does. And there's compelling evidence in research studies that it can be. The ILADS group described chronic Lyme disease as a multisystem illness with diverse musculoskeletal, neuropsychiatric, cardiac manifestations caused by persisting infection. And this is a proposed case definition, and there's now private funding in America looking at why it persists. But why should there be private funding? Studies are coming out of Columbia, from Tulane, from Johns Hopkins, from Stanford, with funding from many different institutions, private institutions, patient groups. There should be funding coming from the Canadian government, the US government, the UK government, the Irish government, from taxpayers' money to pay to understand this better. So does Borrelia finally spread from mother to child? Another contentious issue. Well, this is a slide showing Borrelia isolated in the womb. And are there adverse outcomes? One of the first case reports was Willie Bordorfer, who took the tissues of a baby that had died, of a mom who'd been infected with a rash and classic Lyme disease, and the baby had congenital heart disease. Now, do we need more studies in this? Absolutely. But he found the spirochete that had spread transplacentally to the baby. The baby was dead. So there is evidence that it spreads. This is a case report of neonatal skin lesions, a baby that was born to a mom who had Lyme. They biopsied those skin lesions. In research studies, they were able to grow Borrelia. So yes, Borrelia spreads from mother to child. But there's ongoing debate. Why is there ongoing debate? Because no good science has gone in to follow these pregnant women and follow the babies after delivery. Remington Klein, infectious disease textbooks. I'm an adult and pediatric infectious disease specialist. I read this textbook showing clinical manifestations of congenital Lyme borreliosis. The most recent edition showing in utero transmission, but then out came the ICD-11 codes from the WHO this last year, recognizing congenital Lyme borreliosis as an ICD-11 code, an important landmark so that we can start following these mothers and these babies. And then in November, in PLOS, an article from Canada, doing a really restricted review of congenital Lyme, looking at all the studies. Remington and Klein looked at 800. This group decided to look at very limited studies, 9 studies showing maybe evidence of suggesting transplacental transmission. It's plausible, but why do we have one study showing significant transmission and another study, report showing questionable transmission? So it continues to be a paradox. So the challenge, what is Lyme disease once it's become chronic? I think it's not just an infection. It's a damaged immune system and it's inflammation. And you need to address all of these issues, not just antibiotics. You need to repair the immune system, and you need to do other things to repair the immune system. And patients are doing that, and some of them are getting better. So rather than saying this is voodoo medicine, we have to say, why are patients getting better who are going to alternative therapies because the current system is letting them down? And I use the analogy of HIV and the analogy of transplant medicine. It's complicated. When your immune system gets low, you get reactivation of other infections. You get inflammation, you get damaged immune system. Happens with HIV, happens with transplant medicines. I think Lyme and co-infections are no different. It's complicated. This is a slide that comes from Dr. Spector in North Carolina. It's complicated what's going on in there, and we need to invest money and resources into understanding. The testing is imperfect. We don't understand the complex interactions of infection, inflammation, autoimmunity. Longer courses of treatment and multimodality supportive therapy benefits patients. And people read the mantra, they've done studies and there's no benefit, longer course of therapy. They're bad studies. We need to do better studies based on the new science that have come along in the last 5 years. We need better research, more compassion. If a patient is getting sick and not getting better, we are missing something. Don't blame the patients. Question the science and the failure of the healthcare system. People are not going to private testing and private doctors just for fun. They're going at because the current system's failing them. We need to listen to patients. Just because we cannot find Lyme with current testing, it doesn't mean it isn't there. And then finally, Lyme and other infections spread from mother to child. The effects of the unborn child and infected child is real and needs further study. Thank you.